everyone for joining today's webinar on structural racism and the COVID-19 vaccine, hosted by the Halbram Department of Population and Family Health. Our chair and Professor Terry McGovern will start us off with opening remarks.
Hi, everybody. I'm very, very happy to be having this discussion today. We have amazing panelists. Just a bit about our department. Our department actually focuses on health as a human right and making sure that those for whom that right is most violated, that we are working to really address and have an impact and transform the kind of policies and structures and access issues that are causing these problems. We use science and evidence in partnership with community, really to disassemble the kind of structural barriers that we're going to talk about today. We have amazing panelists, and just so that we can kind of get right into the depths of the discussion with them, I want to do some framing very quickly now. So just very quickly, the global picture, which LaTanya, who I'll introduce in a minute, will be talking about. Just so everybody's on the same page, there's been two approaches. One is the WHO COVID-19 Technology Access Pool, championed by Costa Rica, which really would have aligned with what many have seen out there, the people's vaccine. It promotes technology transfer and the global pooling and sharing of intellectual property so that there's equitable distribution. The second approach is a vaccine procurement effort led by Gavi, the Vaccine Alliance. It's kind of a public-private partnership that is supposedly going to ensure vaccine access through a COVAX facility. It doesn't require technology transfers or the open sharing of intellectual property as conditions for companies to participate, which the Costa Rica version would have. So the WHO proposes each country be allocated a batch of vaccines to cover 3% of the population, enabling at a minimum immunization of frontline health workers. LaTanya is going to go into a lot of details on this, but some governments, especially, and let me just say, of course, the US is not participating. Some other rich countries are not participating in that effort. Some governments, high-income countries, are directly negotiating and funding their own bilateral agreements with pharmaceuticals, universities, research institutes. Others are pledging funds to this COVAX effort. Some high-income countries are doing both. But what is absolutely clear, and LaTanya will elaborate on, is that high-income countries will be likely able to improve their situation the quickest, as will middle-income countries that have vaccine manufacturing capability. But this overall will exacerbate global inequality, not just within countries, but between countries. Some of the countries with the highest per capita death rates will have far less vaccine availability. Just quickly, supply chain issues relate to local capacity and leadership. This will be discussed, but in our current research where we're looking at the impacts of COVID, we've seen consistently that vulnerable, criminalized folks, migrants, LGBTQ folks, adolescents, sex workers, are faring the worst by far in this whole pandemic. So how will vaccine access be guaranteed for those populations? So the current environment has a total lack of transparency. We don't know much about the terms and conditions of funding, who's pre-booked, what for whom, which manufacturing facilities will be used. What we do know, according to Oxfam International, that analyzed all the ongoing global trials, they estimate that 51% of the doses are reserved for high-income countries, even though they only represent 13% of the world's population. So LaTanya will say a lot more about that. You should know that, just like in the HIV days, India and South Africa are trying to get certain aspects of the agreement on trade-related aspects of intellectual property, which gave really long-term patent rights to drug manufacturers. They're trying to get some exceptions, but it's a somewhat troubling picture. We know that the pandemic could push between 70 and 100 million people into extreme poverty, and women bearing the brunt of that. Let's switch to the US and for a second, and we have here people who can discuss this thoroughly, but just to say, the Bronx, Queens, Brooklyn, highest total death rates from COVID, as we know and will be discussed. President Trump invested in Operation Warp Speed to subsidize vaccine. At this point, the Centers for Medicare and Medicaid Services are saying that the vaccine will be covered at no cost to seniors or low-income people in government-funded health insurance programs, that most other commercial insurers and self-funded employer health plans will have to provide COVID-19 vaccines with no out-of-pocket costs. But we know that this space has to be watched very closely, because we have a problem here in the US, which is truly a big topic for today's discussion, which is the history of racism and experimentation in communities of color, the recent history of lies and politicization of science, the ongoing systemic abuse of the very same communities most affected, means we have a tremendous amount of work to do, which is why we're here today. Just some quick examples of structural racism in public health that have fed lots of suspicion. Of course, one of the most blatant examples of racism in scientific research was the Tuskegee syphilis experiment from 1932 to 1972. I think everybody knows that at this point. The US has a heinous history of forced sterilization on communities of color, including the forced sterilization of 3,406 Native American women in the 70s, forcible sterilization of Black Americans even in the 20th century. For example, between 1930 and 1970, 65% of the 7,000 plus sterilization conducted by North Carolina were on Black women. We had a similar problem in 1965 with Puerto Rican women. We also had the first large-scale human trial of the pill launched in a public housing project in Puerto Rico. And there were lots and lots and lots of issues. But, I could go on and on and on about all of this, but we know that systemic racism is present today. Distrust in the system is not just rooted in a few historical examples. We know the data. We know about maternal mortality. And actually, I was thinking about this, and I know Dr. Allen because back in 1987, we were seeing the same people, women of color largely, who were dying of AIDS, actually considered to have AIDS, because the original research on HIV/AIDS was pretty much focused on white gay men. This meant our patients, clients, were unable to access anything. And that's how we started working together. That is what is called structural racism. I'll just quickly say surveys have shown that people of color are less likely to be vaccinated. Black adults are less likely than any other group to say that they would get the corona spike vaccine, citing safety concerns. And I will not take any more time to talk about the incredible disparate impact of COVID on communities of color, Black Americans. And I will close by just saying that what had been overlooked in HIV was the whole concept of converging epidemics and immunocompromise in the context of people living in crowded conditions, in the context of gynecological issues, in the context of people who had lots of other things going on. That all being said, we did see in 1995 kind of a miracle where suddenly there was a treatment. And, you know, I can remember very clearly people dying right before there was a treatment. And the rest of the world waiting years and having to bring lawsuits to get access to what would keep them alive. So we do not want to be in the same situation now with COVID and the vaccine. So we have to have a frank discussion about what we know, what's true, what isn't, and then kind of really figure out an approach. And that's the point of today. So I am really, really happy to introduce the panelists. The first is Dr. Michelle Allen, who is the Senior Vice President and Chief Medical Officer at New York City Health and Hospitals. She previously served as the health system's interim CMO, and prior to that as Deputy Chief Medical Officer since October 2013. A long-standing veteran of the health system, she completed her residency in OBGYN at NYC Health and Hospitals Jacobi, worked as an attending physician at Harlem and Bellevue, which is how I know her, and served as the Associate Medical Director at Bellevue until 2013. She's a graduate of Cornell and University of California, San Francisco School of Medicine. For you students who are on the line who want to know how you can be a professional in public health and maintain integrity, I direct you to my friend, Michelle Allen. And I have many, many examples for another conversation. Next, I'll introduce LaTanya Mapp Frett, who is the Chief Executive Officer at Global Fund for Women. She's also an adjunct, we're happy to say, in the department. She was the Executive Director of Planned Parenthood Global, and she quadrupled the size of that program in 4 years. She worked for 8 years as a Human Rights Officer for UNICEF, 10 years with USAID. She was at Beijing as a delegate in 1995. She's an attorney who began her career at the NAACP Legal Defense and Education Fund. She has lots and lots more, and we're really thrilled to have her here today. And last, of course, not least, is Dr. Michaela Martinez, who is an infectious disease ecologist. Her focus is on understanding the drivers that shape seasonality in infectious disease systems. Her current projects aim to inform vaccination policy by revealing how demographic, physiological, and environmental factors intersect in epidemic-prone disease systems. She does research on maternal immunity in infants and building a statistical inference pipeline for studying vaccine modes of action. I would say all three of these folks are absolutely most concerned about community impact and I would say disassembling structural racism. So thank you all for being here. And I am going to start with Dr. Martinez, with the question, can we trust the science here? What has happened? Does Operation Warp Speed mean that, you know, we really can't trust what they're going to put in our arms? Dr. Martinez. You're muted. Oh.
I'm muted, sorry. Thank you for that, Terry. As Terry mentioned, I've been charged with talking a little bit about the vaccines and the vaccine trials. So this is going to be pretty US-centric. I'm going to focus on the two vaccines that are being used in the US with emergency use authorization. And the first thing to let you know is that these vaccines they're not licensed. They have this very kind of special permission by the FDA to be used, which is emergency use authorization. And there are essentially three criteria that have to be met to allow this. One is the EUA, emergency use authorization, can be approved if there's need. So there is a need for the COVID-19 vaccines because of the crisis that we are under from the pandemic. And then the other two things is that the risks have to outweigh the benefits. for emergency use authorization, which means that, or I'm sorry, I said that backwards. The benefits have to outweigh the risks. So that means that the benefit of allowing a vaccine to be used temporarily through this authorization has to outweigh any risks that can come from vaccinating. And then the third criteria is that there essentially has to be no other option. So there's not already something that's licensed on the market that can be used for prevention and treatment. So we have 2 vaccines that right now have this authorization. And like I said, this authorization is more for temporary use rather than for long-term, which is what happens for vaccine licensure, and it takes much longer. So in terms of the very rapid production of COVID-19 vaccines, some of this speed has been due to the fact that there had been vaccines in the works for other coronaviruses. And so some of the technology platforms were able to be pivoted to be able to speed up development. The other thing was in the United States, there was a lot of essentially prep for the manufacture and delivering of vaccines that kind of came before we actually knew which vaccines we would have that would be safe and effective. So that has been another part of Operation Warp Speed, but I'm not going to go too much into that. What I wanted to do was just to give you a little bit of information about who was in these vaccine trials and a little bit about each of the vaccine trials. So both of the vaccines that have the EUA in the United States, these are mRNA vaccines. And what that means is that these vaccines contain a genetic template that once the vaccine is in the body, they essentially can allow your body to start coding for the protein that is a spike protein on the outside of SARS-CoV-2, the coronavirus that causes COVID-19. So what happens is our bodies then can start producing this protein based on this mRNA template, and that allows the B cells in our immune system to be able to recognize this protein and produce antibodies that are specific to binding to that protein, such that if you're ever exposed to SARS-CoV-2, you have those antibodies that can go after the virus and do that specific binding. Now, for both of the vaccine trials, the efficacy of the vaccine was gauged in the following way. So for each trial, they enrolled individuals. This ranged from 30,000 to 40,000 individuals, depending on which of the 2 vaccines we're talking about. And then individuals were randomly placed into 2 groups, a placebo group and a control group. And then on average for about 2 months after the vaccine was given, so each vaccine is 2 doses. You get 1 dose and then people have to come back 21 to 29 days later, depending on which vaccine, and get the 2nd dose. And so after the 2nd dose is given, then the people are given anywhere from 1 to 2 weeks to make sure that both doses of vaccine have been in their body enough that their body's producing antibodies. So then after this time, then the clinical trial team started to track for how many individuals have symptomatic COVID cases. So they were looking out for things like fever, chills, loss of smell. And when individuals would report, whether they're in the vaccine group or placebo group, that they had any of these symptoms, then they would be brought in for a swabbed, PCR test done to see if they actually have COVID. And if they do have a COVID case, then they get marked down as being a COVID case. Now, in the end, what happens is, in terms of measuring efficacy, is a simple calculation of how many symptomatic COVID cases do you have in people vaccinated versus how many symptomatic COVID cases do you have in people that were given the placebo. And the difference in those 2 tells you how effective it is. So there were 95% less, essentially, COVID cases in vaccinated individuals than placebo individuals. In both trials, it was between 94 and 95%. Reduction in COVID cases, and then that's what's used as the efficacy outcome. Now, who is in these trials? So as I said, each trial had 30 to 40,000 people, so split in half placebo and control. So we're talking 15 to 20,000 vaccinated individuals in each vaccine trial. Now, when it comes to the demographics of these trials, there were about 50-50 split between men and women. And both trials very closely match the demographic profile in the United States. And so for the, I think that was what they were trying to do, essentially. So for the Pfizer vaccine, 81.9% white individuals, 9.8% African American, 0.6% Native American, and 26% Latino. And so there is not equal distribution of racial and ethnic categories within the vaccine and placebo recipients. Rather, they went based off the demographics of the United States. Now, the Pfizer vaccine, interestingly, I don't think this has been publicized very much, that was actually done in a number of countries. So these individuals were not all in the US, 76% were in the US, 15% were in Argentina, 6% in Brazil, 2% in South Africa. So these people, vaccine participants or trial participants were enrolled from around the world. Some individuals were also enrolled that had comorbidities that we know are risk factors for severe COVID. So for the Pfizer vaccine, 35% were obese, 8.4% had diabetes. And then within Moderna vaccines, the numbers are really similar, 79% white, 9.7% African American. The Moderna vaccine, interestingly though, or I think importantly, all of the individuals were from the United States, and the Moderna vaccine the people who were given the vaccine, they came from 99 different sites throughout the country. So they were trying to have a geographical representation of the US. And now just with my last minute or so, because I don't want to go over in time, I just wanted to talk a little bit about the adverse effects that we're seeing for both vaccines. So I'll say for both vaccines, adverse effects were fairly common. Most of them were relatively mild. So for instance, for the Pfizer vaccine, reactions at the injection site happened in 84% of individuals. Fatigue happened in 62%, headache in 55%. What this means is that the majority of individuals are experiencing these relatively mild symptoms. Now, when it comes to severe adverse effects, and what I should say is that for both vaccines, individuals were monitored on average a couple months after they were given their second dose. So the adverse effects are these really near-term adverse effects. So between 0 and 4.6% of participants given the Pfizer vaccines had severe adverse effects. And the reason it ranges from 0 to 4.6% is because the FDA is still trying to work out which adverse effects are due to the vaccine versus just random chance that they happen to people. The most common for both vaccines was essentially a swelling of the lymph nodes. Also had an individual who had shoulder injury from the vaccine, another individual who had some arrhythmia, someone with a heart condition in the vaccine caused arrhythmia. There's also an individual with appendicitis, and then probably the most concerning is in the Pfizer vaccine, there were 4 individuals with Bell's palsy in the vaccinated group. And for that vaccine, there was nobody in the control group or the placebo group with Bell's palsy. This is a facial paralysis. And so the FDA is still trying to determine if whether or not those Bell's palsy cases were by random chance or due to the vaccine. Now, in terms of the Moderna vaccine, there were 7 severe adverse events. These include 1 individual with nausea and vomiting, 2 individuals who had facial swelling. There was another case of Bell's palsy, and then a triggering of rheumatoid arthritis. And so what all of this is to say is that depending on which vaccine you're looking at, you have anywhere from, and how we attribute the severe adverse events, you have anywhere between 3 and 7 severe adverse events that are happening in individuals. And these are ranging from things from nausea and vomiting all the way to facial paralysis. And these 3 to 7, we're talking about 3 to 7 severe adverse events in anywhere to 15 to 20,000 individuals. And so that's the risk that we have documented for each of these vaccines. Now, when we think about the benefit, each of these vaccines is conferring a 94 to 95% reduction in COVID-19 cases. And right now in the United States, we have about 1 in 1,000 Americans has died of COVID. So when we do this risk benefit calculation, there are some adverse effects due to the vaccine, and they will probably understand those in more detail in the months to come. But those adverse effects are outweighed by the protection that is conferred. And that is why both of these vaccines were given emergency use authorization. And then with that, I'll hand it over.
Thank you, Dr. Martinez. That was a really brilliant summary of a whole lot of complex stuff. Thank you. I want to turn to Dr. Allen and ask about Health and Hospital Corporation's plans for rollout and how some of these issues around mistrust will be addressed. Dr. Allen.
Yeah, thank you, Terry. For the audience, I just want to refer back to something that Terry had said. And it was about collaboration, myself being a clinician, seeing patients, Terry being a lawyer, litigating for those patients, and bringing those two disciplines together to effect change. Terry successfully sued Health and Human Services Agency on the federal side to make sure that women were included in the diagnosis for AIDS. No small feat. So what I'd like to do is share with you a literature review which was done by a young attending in our department around structural racism and COVID. So let's start off with the disproportionate impact. Multiple studies have shown the disproportionate impact of COVID-19 on minority populations in the United States. Counties in the United States with larger Black populations experienced an increased rate of COVID-19 cases, even after accounting for other community level factors such as household size and education. State level analysis has shown an increase in COVID-19 death rates in our states with larger percentages of African American residents. And the CDC has found the largest percentage of increase in excess deaths among Latinx persons and intermediate increases among Black, American Indians, Asian populations. The Kaiser Family Foundation has developed a COVID-19 vaccine monitor to periodically assess vaccine attitudes among the public. While the overall vaccine interest has increased, there is a disproportionate number of Black respondents who express an unwillingness to receive the COVID-19 vaccine, even though it's been deemed safe by scientists and free of cost. Additional factors that appear to correlate with vaccine intent include the individual's vaccine history, their perception of COVID-19 as being a serious problem in the United States, the effectiveness of the COVID-19 vaccine, and the likelihood of getting COVID infection in the future. The Kaiser Family Foundation also shows increased vaccination hesitancy among other populations, including Republicans, individuals between the ages of 30 and 49, and individuals who live in rural settings. All definitions of structural racism make clear that racism is not simply the result of a private prejudice held by an individual, you or me or someone else, but it is also produced and reproduced by laws, rules, practices, sanctioned and implemented by various levels of government, and embedded in our economic system, as well in the cultural and societal norms. So confronting racism therefore requires not only changing individual attitudes, but transforming and dismantling the policies and institutions that undergird United States racial hierarchy. Three interrelated domains in which structural racism affects individual health include redlining and racialized residential segregation, mass incarceration, police violence, and unequal health care, which we discussed earlier, the legacy of scientific racism and eugenics, inequitable care, under-resourced facilities with fewer clinicians, our Black communities servicing as medical training grounds. Looking at the historical reasons why some populations, especially Black Americans, are hesitant to enroll in clinical trials, our country has yet to comprehend adequately that overcoming racism is not primarily the responsibility of Black people. The racist ideas and practices that constitutes today's structural racism were created and have been sustained primarily by white people. It would be wrong as well as ineffective to ask Black communities to simply be more trusting. Clinicians, investigators, pharmaceutical companies must provide convincing evidence sufficient to overcome the historical evidence of the contrary, that they are in fact trustworthy. Speaking to the definition of vaccine hesitancy, it's been defined as the delay in acceptance or refusal of vaccination despite the availability of the vaccination services. Vaccine hesitancy is complex and context specific, varying across time, place, and vaccines, and is influenced by many factors. It's important to distinguish between vaccine hesitancy and other reasons which may decrease vaccine uptake, like limited stock, limited access, etc. So the correct interventions are implemented to increase the vaccination rates. Vaccine hesitancy can be understood using the vaccine hesitancy determinants matrix, contextual, which would be those influences arising due to historic, social, cultural, environmental, health system, institutional, economic, or political factors. Individual and group, these are the influences arising from personal perception of the vaccine or influences of the social peer environment. And vaccination specific influences, specific issues directly relating to the vaccine or the vaccination. There was a review looking at how to address vaccine hesitancy within the literature. 181 articles were reviewed, and in fact, very few strategies explicitly are designed to address vaccine hesitancy, and fewer quantified the actual impact of the interventions. The interventions that were utilized were multi-component strategies, which include knowledge and awareness strategies, and those in fact were inadequate in and of themselves. Those interventions which had greater than a 25% positive impact included directly targeting the unvaccinated or the undervaccinated, an aim to increase vaccination knowledge and awareness, improving convenience, improving access, targeting specific populations, mandating the vaccination, or sanctions against those who did not vaccinate, and engaging religious or other influential leaders to promote the vaccination. The greatest increase in knowledge and awareness or attitudes were observed with education initiatives, particularly embedding the new knowledge into routine processes. In addition, tailoring the intervention to the specific population. What was least effective were interventions focused on quality improvement in the clinics, passive interventions such as posters and websites, incentive-based interventions, and reminder recall interventions had variable results. So looking at literature out of the United Kingdom as well as literature from Harvard, Blacks, Asians, minority, and ethnic healthcare workers had a 5-fold increased risk of COVID-19. And when we look at the impact of COVID-19, it's not only the seropositive or the prevalence of the virus in the community, which is the case rate, looking at the hospital rate and the fatality rate, and all three are increased in underrepresented minorities, Black and Latinx specifically. And among healthcare workers, if you look at the environmental staff, the transporters, and the food service staff, they had a 10 times higher rate than the frontline staff who were higher waged, such as the doctors and the nurses. If you look at attitudes towards vaccination, if you look at who would be vaccinated immediately, that would be 42% of Blacks, 61% of Latinx, and 63% of whites. And looking at trust, 14% of African Americans surveyed said that they mostly or completely trusted the vaccine safety. That's 14% trusted the vaccine safety. 4% of African Americans trust the current administration. And 83% of African Americans think Trump is a racist. So that's what's in the literature. Here at Health and Hospitals, I have the opportunity in my particular role to walk around each of the hospitals and talk to the staff, which I've been doing frequently. And an interesting observation, when you go up to a unit, especially a unit where they're wearing scrubs, the staff who are in blue scrubs are doctors. The staff who are in maroon scrubs or beige scrubs are not doctors. And as I talk to the staff, those who are in blue scrubs have been vaccinated. Those in the maroon and beige scrubs have more questions, and very legitimate questions. When I ask those who've been vaccinated why they got vaccinated, they say, for my family, for my children, some say for my patients, need to keep my patients safe. One particular poignant story that a person shared was that in order to get to the hospital, she had to walk by the refrigerated trucks which contained the dead bodies, and she didn't want to be one of the bodies in those trucks. When I asked the staff who did not get vaccinated, why not? They said the vaccine was rushed. They actually speak to warp speed. And they want to know, what are the long-term effects? Have we been studying this long enough to know what the long-term effects are? What's the data? How many information that Michaela shared earlier? How many people were in the studies? Who were the people in the studies? What happened to the people while they were in the studies? And then I asked them, well, if you had my job, how would you handle this? What's your recommendation to me? And what they essentially said is we need the right messenger to deliver the right message to the specific audience. So I got a range of answers. Many people just wanted the data. Some people wanted to see their leaders get vaccinated. Some actually didn't want to see the leaders. They wanted to see their peer and what happened to them. One amusing story, one of the staff members, I asked, well, it's the watch and wait. What are you watching? What are you waiting for? And one woman said, well, I sent my husband to get vaccinated today. I want to see what happens to him. So there's a sense of humor as well. What are we doing here in Health and Hospitals? We're doing a multimedia campaign. And let me just say the other thing that unanimously was suggested, that there be one-on-one conversations, not huge meetings. They want it to be personal. They don't want to be judged in a group. There is a paper out of Brigham Women's where they actually embarked upon an educational campaign, which I was actually impressed with, that they had small groups. The manager who joined the group was not their manager, so there was no fear of judgment. They actually had their meetings at change of shift. So tour 1 starts at 11 p.m. So they would have a meeting at 11 or 11:30. It ends it's 11 to 7. They would also meet at 7 a.m. for that change of shift as well. We are doing town halls, but we're taping our town halls so that any staff member can actually download and watch. We realize that most of our staff are not sitting in front of their computers all day long. The nurses are actually taking care of patients, not sitting at a desk. Environmental services are out there cleaning. Food services are delivering. So we tape our town halls. We take questions and answers. We try to share the data about the research trials, about the vaccine makeup, explain herd immunity, and what Michaela shared, the timeline of development. We have videos of many of our staff getting vaccinated. Harlem Hospital has been very active in using the social media and videos. Where the leaders are African American or Latinx, videos of them getting vaccinated. We're also encouraging our staff to take selfies when they get vaccinated. They have the same backdrop I have here, and they can take a selfie of themselves and their friends. They can come down with their buddies and share on social media. I'm not on social media. I tried to share. I have one follower, my daughter. She was very enthusiastic. We also have what we call vaccine champs, the members of the staff who have gotten vaccinated and are our ambassadors. Our plan is to reach out to our elected officials. You know, we have 11 facilities in four of our boroughs. We're not in Staten Island. We have an ambulatory setting in Staten Island. We don't have an acute care facility, but to reach out to our elected officials to support. We will also be talking to our union leaders if they're willing to support as well. We have an employee survey going out this week, so we have a better idea what the right message would be to our various staff members in the population. And I'll end there, Terry, and turn it back to you.
Thank you so much. That was really, really, really helpful. And I think we're trying not to do any panels that are just about the US, because the US is in fact part of the globe, despite our president's attempts to remove us. So I'm very, very excited to have LaTanya here. So just a word on what LaTanya oversees. Global Fund for Women kind of consistently throughout my career, the best groups, the most fierce, on the ground, challenging all of the structural racism and misogyny all around the world are Global Fund for Women grantees. So I thought there was no one better than to discuss kind of the problem on the global scene than LaTanya. So LaTanya, tell us what you're seeing, and welcome.
Yeah, thanks so much, Terry. And it's such a pleasure to be here with you guys. I'm learning more about what's happening here in the US, because my eyes have been focused. And as you said, I mean, with Global Fund for Women, we have partners in 175 countries. And so while I can't talk about all of those, I'll try to talk about it sort of regionally and how we see it. We do know through our partners, and since COVID has hit all of us, and we've been enormously affected by it, that it continues to lay bare, the systemic inequities. And I mean, racism, structural racism is just one of many systemic inequities built into our world, and that gets sort of hyper, lifted up under pandemics. What I do think, what I know is that women, girls, and marginalized communities in particular, not just here in the US, but all over the world, have been hard hit. Women and vulnerable groups are facing this increased domestic violence, restricted access to reproductive health care and rights and this heightened caregiving burden. I mean, if we think about what happened, the three, so wash your hands, social distance, and stay at home, we know that there's been, for many of our partners, those three have been extremely challenging. And so think about parts of the world where just basic sanitation is not as readily available as you would have here. That's been the first thing that a lot of our partners have been trying to do, is to figure out how to get antiseptic to places where there is not soap and water readily available, and how to do that in a very quick rollout way has been just the most amazing thing that I've ever seen coming out of many of these women-led organizations that we fund. The second one about social distancing, which, as many of you know, doesn't even translate in a lot of languages, the ability to be able to be in a space by yourself, not to mention 6 feet apart, has been very difficult. And so coming up with solutions to that for, extended families, multiple families that live together in homes, not to mention in compounds where they live. And so that has been a big part of getting that information out, and how to even explain what that means to social distance has been a very real effort, particularly the first few months. And then, of course, staying at home. And we know from many parts of the world, home can be a dangerous place, particularly for girls who have been schooled at boarding schools, who have now had to come back home and face circumstances, situations that have not been healthy for them. So that's been what we're seeing, a lot of what our partners have been challenged with and trying to get out. We do know, I'll give a little bit about sort of because I think it's important to think about the size of all of this, though. So we know in Americas and Europe it's the worst outbreaks. That's the region with the most cases. The Americas, combining North America and South America, have had about 38 million confirmed cases, followed by Europe, which is about 28 million cases. And then Asia, which drops down to about 12 million cases, confirmed cases. The Middle East, about 5 million confirmed cases. And then Africa, and I'm talking rough numbers here, in Africa, about 2 million confirmed cases. And so, I'll talk about emerging hotspots being in South Africa, Brazil, Colombia, Chile, Iran, Kuwait, in the Middle East. And so we know that they're emerging hotspots, and they take up many of the numbers of those that I just listed about overall numbers. But of course, as you can see, the difference between 38 million and then 2 million in such a large region as Africa. We are, the populations and the problem is different. And so understanding that as we talk about the vaccine rollout is going to be really important. But I do want to go back to what Dr. Allen was saying about the inequities, are very much similar. When you start to talk about what we see in systemic issues that are happening in these parts of the world, very, very similar. But we did see that overall populations and regions that have experienced novel viruses before would seem to be a little bit more prepared, right? So countries that have dealt with SARS or MERS or Ebola had some infrastructure in place as they moved through the last, what I would say, 9 to 12 months of this issue of the pandemic. And what you will also see is that many middle and low income countries have outperformed the US on the pandemic, with some compelling examples really of, and I think this was the first word that Dr. Allen used, was collaboration between health and other sectors. And then also with the healthcare workers really effectively advocating for support. So a lot of that sort of language and translation that I talked about was coming from the healthcare workers themselves. Then, of course, mobilization of private sector resources has been a lot easier in some other places than it has been in the US and Europe. And then leveraging existing systems that were built for other national health issues, such as HIV or Ebola, to combat the pandemic. So those are the good things that we saw happening, and I wanted to bring them up first. Because, of course, there's a however, and there's the challenges to the progress against other diseases. We have seen things in the healthcare system like HIV treatments being stopped. We saw low access to, if at all, reproductive health and sexual health. And so we continue to monitor that, and the groups that we work with continue to talk about those issues and how to advocate to ensure that they stay in place. The global vaccine picture, when we look at the structural racism that's plaguing, I know Terry mentioned some things which I'll go over again, but the problem really is global. We talk about structural racism, and then we talk again, which would, closely align, the income inequalities. The process of advanced purchase of these vaccines has meant that whatever country can pay the most at the earliest stage of the production gets at the front of the queue. Rich countries are hoarding the vaccine supply, including ours. And so almost 10 billion doses of the vaccines are out or near completion, and they've already been reserved. And the vast majority of those doses have been purchased by high income countries. The US, for example, has purchased 2.6 billion doses for about 350 million people. And so when we're talking about 7 billion people, it does become a concern. As of November last year, we didn't see any direct deals being made by low-income countries to buy the vaccines. And so then this comes what Terry mentioned, the COVAX and other sort of programs to try to get this under control. And COVAX is the WHO's, the World Health Organization's program. It's their vehicle to vaccinate people in poor and middle income countries around the world against the coronavirus. And it aims to deliver at least 2 billion vaccine doses by the end of this year to cover 20% of the most vulnerable people in 91 poor and middle income countries. Mostly they're in Africa, Asia, and Latin America. But it is struggling. COVAX, if I understand the numbers, has at this point raised only 2.4 billion, which means that for vaccine purchasing alone, they need 4.6 billion more in order to meet its $9 billion goal of purchasing these vaccines. And then there's, of course, the cost around logistics, which are going to be very high. And I'm understanding there are about $1.5 billion required for logistics, which is still not there. And then, 500 to 800 million, I believe, that's going to be used for research and other issues. And so I don't know how else to say this, but there's a very high risk of failure here. And even according to Gavi themselves, that potentially we'll have to leave nations, which is home to billions of people, without access to this vaccine until probably something more realistic like 2024. It's underfunding, and its goals for other countries is part of the issue. The issues around transportation, storage, health infrastructure, to distribute the vaccine, or other issues that are going to have to be tackled. So basically what it boils down to is that low-risk people in the US, and I'll just use the US because we're here, will likely be immunized before many of the high-risk people in poor countries. And so that's going to be a huge challenge. We're going to have a long road ahead internationally for widespread vaccination. And then let's get to the other issues around vaccine hesitancy and systemic racism. And some of the things, I think the examples that have been given here are very good. Anti-vaccine sentiment in Africa is very high. Seth Berkley, who runs Gavi, said it's the worst that he's ever seen in his career, and very good reason. There's a legacy of racism and colonialism that is very much alive still today. Last year, the French researcher, some of you probably saw, Jean-Paul Mira, said that shouldn't we be doing this vaccine study in Africa where there are no masks, no treatments, no resuscitation? He compared it to AIDS studies. He said in this report, in prostitutes, we try things because we know that they are highly exposed and they do not protect themselves. And so this is the sort of rhetoric that they're hearing in Africa. And it's actually led to protests in South Africa against using the continent as a dumping ground for vaccine testing. And these fears are grounded in histories like in Nigeria, where several children died of meningitis in a Pfizer clinical trial for an oral antibiotic. And earlier this year, South Africa's Commission for Gender Equality and dozens of HIV positive women have been forced or coerced into sterilization after giving birth at public hospitals. So these things continue. And so it's very difficult. And I think one of my colleagues just mentioned to just say, get past it, take the vaccine. And so we're really going to have to deal with that. This distrust globally, I think, particularly as it applies to race, is going to continue to, and I heard it here already, require that the right message goes to the right audience, and it has to be from a trusted messenger. We can't assume that people are just going to be okay with taking this vaccine. We need to very much work together to make sure that the trusted messengers have the right information and can get it out there. And that, of course, there's clear, transparent communication in the right language, because sometimes we forget that's just hugely important. So people who don't speak English or French or other languages in which these vaccine companies are using are going to be the least likely to want to move ahead with vaccination, because they just don't have the right information in their languages, and they don't get the questions answered by way of the way we're doing it today. And so for us, and I'll just, stop here, but for us, it means that there's very few ways to get correct information out in systems where, the healthcare structures are not strong. And that usually rolls back to grassroots organizations and movements to do that work. That usually means that it's women, whether in your role as a public figure, and more likely as a mother, as a sister, as a PTA member. That's where that information is going to have to come from in most of the countries that we're talking about. And we want to be able to fund these community organizations, these grassroots movements, because they are trusted by their communities, and they respond holistically to the pandemic and its effects, and they keep things like systemic issues in as a background to the way that they talk to communities. We have a grantee partner in the Democratic Republic of Congo that I remember, who had done a lot of work around the Ebola virus. And they were just quick to get information out, because they felt like that was the best way for us to start handling the current pandemic, was to make sure that information was fairly, equitably, reliable, trustworthy, and get that out to their communities. They did it via radio and television. And that's the kind of thing that we really have to think about in countries where they're not going to have a vaccine for a while, but at least if you can start getting that information out, that they'll be more comfortable with the vaccine when it does get there. And this kind of like hyper-local tailored communications are going to be necessary to build trust, in my opinion. So thank you.
Thank you, Latanya. That was really, really, really helpful. We have already a bunch of questions, but I did want to just comment again that we have no information on what it actually costs to create vaccines. There's no transparency around that, which of course was also the issue in HIV with development of drugs. And so just to kind of throw in there corporate accountability, particularly when we're talking about subsidized research, right? So just that's at play here in a big way. So we have questions. This one is a good one. In response to the New York Times article that came out this weekend about some medical centers, including Columbia and NYU, vaccinating non-clinical staff, do speakers have thoughts on this important issue, which could be seen as a form of structural racism? So that's a good question. Then we have another one. I'll let you think for a few minutes. That is with respect to women and maternal infant morbidity and mortality. Is there an update on vaccine efficacy and potential health concerns for pregnant women, especially BIPOC women?
So I'll take the OB one. I'm not going to take the first one, other than to say we're in a bind. There is a rollout structured that was designed by the governor. Healthcare workers, frontline workers, emergency room workers, ICU workers, then roll out to other healthcare workers who are exposed to the virus. And following that rollout structure, everyone was criticized for not using all of their vaccines. So over the past 4 or 5 days, the rollout has been expanded so that we are now vaccinating teachers and people over the age of 75. So it's a bit of a tension point following the rollout structure, but getting everybody vaccinated at the same time. And it makes it very complicated when you have these strata of risk. Healthcare workers are, of course, prioritized. Essential workers are prioritized. But I was at another hospital this morning and traveling. The person who was driving the car, who was African-American and obese, whose wife had COVID earlier, who sleeps with oxygen, said, Dr. Allen, when can I get my wife vaccinated? So we have to chew gum, walk, and stand on our heads at the same time. But in terms of pregnancy risk with the vaccine, Michaela will back me up on this. Pregnant women were not included in the trial. So we don't have any information. So it's a risk-benefit balance. What's the risk of getting a viral pneumonia, which is a very high mortality rate, and even higher with the COVID pneumonia, to develop adult respiratory distress syndrome, renal failure? What's the risk of getting COVID and suffering the morbidity and mortality of that alone versus the risk that we're seeing with the vaccine in the rest of the population, which is some mild or moderate, but very few adverse impacts. So what we're recommending is that pregnant women have a conversation with their obstetrician, review their personal risks, personal benefits. If they're, if they've already had cancer, on chemotherapy, immunocompromised, have all the other medical conditions, the obstetrician and the woman will probably have a conversation that would be to their benefit to take the vaccine. It's an individual decision. After that conversation, if a pregnant woman comes to us and asks for the vaccine, we will vaccinate her. I hope that's helpful.
Yes, thank you. Michaela, you want to add anything there? Or?
Yeah, just in terms of the maternal vaccination, for protecting pregnant women, either you vaccinate the pregnant women or do cocooning is another strategy. If vaccine were more readily available, you vaccinate individuals that are in close relation with the women to essentially form a protective barrier of immunized people. One of the other potential benefits for vaccinating pregnant women when we're thinking about the risk-benefit relationship is that pregnant women will transfer maternal antibody to their fetus during gestation and then also during breastfeeding. So, there can be these secondary benefits, which is one of the reasons why we have maternal immunization, like for flu is to protect the mom primarily, but also some potential benefits to the baby. But I will say that I have heard discussion about the kind of unfair distribution of vaccination. And I agree with Michelle that it's, essentially a side effect of this logistical nightmare. But I also do feel that it is a very kind of grotesque display of privilege that some of our institutions have had this access when so many others don't.
Yes.
Yeah, and Terry, I just wanted to add on the article too. I actually didn't read it, but I do know that, and it was mentioned, I think, in someone's initial remarks, that it's going to be important, especially overseas, that we see, because the first rollout group, like it is here, will be healthcare workers and other frontline workers, that we do see some politicians and other sort of leadership, whether that's in a community, organizational, or countrywide, take the vaccine before it's given, for all the issues that I talked about with sort of the mistrust around the vaccine that we'll have to see some people taking it that are not early on, that are not healthcare workers. We've seen that in the US. We've seen a lot of politicians sort of do that. And I think that that might be a practice that we want to see in other countries around the world so that people can start to get comfortable with the vaccines. And you haven't seen that much. And I did also want to mention that I think when we're talking about vaccines in the US, we're mostly talking about Pfizer and Moderna. And all of those cases that I was talking about with COVAX, they haven't actually given, they haven't done anything. They haven't committed yet to World Health Organization. And so all of the other vaccines, I think from India and China and the other ones in development are the ones that we're talking about being committed under COVAX and not the current ones that we're using here today. So unfortunately, we can't look to the US and some of the other, the UK either for examples, because I think, I can't remember the number exactly, you guys know, but we've vaccinated like, millions and millions of people already. And we've, been through enough time now to see if there was going to be any gross problems. And so that, because it's not the same vaccine for other parts of the world, it's going to be hard to look to the US and parts of Europe right now for any indication of what would happen when they get theirs. So just wanted to point.
Thank you.
And I actually wanted to make one note about price, because Terry had mentioned the price of the vaccine that we don't really know, but just to give people a benchmark. So the inactive polio vaccine, which is also an injectable vaccine for Gavi supported countries. So these are countries where you'll have mass polio immunization. It's at $1.81 per dose for Gavi supported countries. So when we're thinking in our head, like what does the price point have to be for these COVID vaccines or for an injectable vaccine to be able to go global, those are the kinds of numbers we're talking about.
Yeah.
Okay. So we have a bunch more questions. One is, what does vaccine distribution look like among folks who are undocumented and aren't eligible for government or employer-sponsored health insurance? I'm going to say two at a time. In regard to vaccine hesitancy, how can we foster hyper-local responses at a massive scale rapidly? Rapid scale approaches tend to focus on standardization, what elements can be standardized and what can be adapted locally by grassroots organizations and others. So what does vaccine distribution look like among folks who are undocumented and aren't eligible for government or employed sponsored? And what about standardized rapid scale approaches? What can we adapt them?
So I can speak for New York City Health and Hospitals. We actually do not ask for persons' legal status, citizenship, and we don't charge, period. So Health and Hospitals is there for the undocumented and the uninsured, as always. I don't know if there are any other comments.
Yes, Michaela, were you going to speak?
Oh, and LaTanya could speak to this in terms of COVID vaccination and grassroots efforts. But I'll say that historically, we do have one example of mass mobilization of grassroots efforts for vaccination. And that was when the Pan American Health Organization mobilized women throughout Latin America to vaccinate against polio. So essentially, the public health message was get women from each community, mothers and grandmothers, to make sure that all of the children in their families and communities were vaccinated. And that was one way, that was a reason why Latin America was the first to get rid of polio, was through that. So we have an example of it happening.
That's great.
Yes. And I would just comment on two things, and so Dr. Allen was saying in New York City, it's, it's free, they don't ask for status. I don't know if that's throughout. I just read something about Texas. I don't know if you saw that. So I don't think throughout the country it's very clear. And so again, it goes back to the messaging and again, back to the grassroots organizing and sort of translation and who's the messenger. telling people. So if you don't know it's free and your status won't be asked, you won't know to come because you'll think that you won't be able to get it. So that is definitely one piece that I think, and I'll lift that up because of the question around grassroots mobilization. If someone who is undocumented tells another undocumented person that it's free and they can get it and it's fine, then you'll have people coming. Otherwise, they won't know that. And based on, quite frankly, our history and even the past 4 years, I don't know why anyone who probably doesn't speak English or doesn't read English would have any confidence in coming to a public health structure and expecting a service, a human service, and someone to talk to them about this one-on-one. So I think that amplifies, and what Michaela was saying about Latin America was the same process in Africa. So you really do, I think when you talk about grassroots efforts for public health issues, and in particular a pandemic, it is probably the most effective tool that you have at your hand.
Yeah, Michaela, go ahead.
And I just wanted to make a comment on the free and the uninsured and undocumented status, because I think that's something that all of us, just like as citizens, should be very aware of, is like how you might have infrastructure in place to be able to offer to people services, but because of racism and essentially classism and such that exists, sometimes these may not be accessible. So for instance, I was getting a rapid test at one of our free locations here in New York City in Washington Heights last week, and someone came in that spoke Spanish. And this is a neighborhood where a large percentage of the population speaks Spanish, but nobody there of staff spoke Spanish. So then this person was about to leave, and then a Spanish speaking another patient had to step in. And then also, even though it's supposed to be free for everybody and you don't have to be insured, another person came in, and the woman at the desk says, "Oh, well, do you have your insurance card?" And so I said, "Isn't this supposed to be free and you don't have to be insured to get it here?" I'm pretty sure that they don't have to have an insurance card. And that was the case. They didn't have to have insurance, but they automatically ask for insurance. So I think it's going to be up to all of us to try to like have these conversations to essentially check other people in society about how to navigate these situations, because even if the safety net is in place, doesn't mean it's accessible.
Thank you. Just we have another question, but I just wanted to say, I mean, we should have learned from HIV that this is the way this will play out. It was activists and advocates who we had treatment here in the US, and we had people dying all around the world. And it was really grassroots folks and activists who pushed for a public health exception to these long-term patents. And it was also women who, women actually had to infiltrate all levels of kind of governance around HIV to actually even get acknowledged, right? And we learned in Ebola that, when you issue a stay-at-home order, gender-based violence rates are going to soar. And we know that in many countries, including this one, any crisis is used to shut down access to sexual and reproductive health, gender-based violence services. So I guess my question is about leadership. We certainly see in the US a lot of leaders fighting with each other. We also see kind of everything we know being ignored. So I'm just wondering, about your thoughts on this. Like, how do we, in places where there are leaders who understand structural racism and intersecting impacts, things actually do turn out better. So any comments on the kind of politicization leadership issue? Latanya?
I'll go first. And I mean, it's just, I sometimes worry about the Biden administration. There's so much hope on what's going to happen when they finally get in there and what we need. But I do know that, coming out of WHO under our current administration has had a huge impact. I mean, we didn't even know, about the virus when all that happened, but that we're not a part of that whole structure that has been built now. We're not a part of COVAX. And it means things to me like, Pfizer should be a part of COVAX, right? So leadership is going to be hugely important. Because we could say things like, well, we're going to buy 2 billion for our 350 million people, but we also very much expect you to be a part of the solution for getting it out to the other 175 countries in the world, right? And so we really do need that leadership to happen. There's been a lot of missteps that have happened by us sort of not being at the table. And not that the US at the table is the answer, but it does help with the resource conversations. It helps with, we are the largest funder of global health in the world. And so how we utilize those resources can shift because we have a global pandemic, and that really hasn't been done. And so those are things that require leadership that we actually don't have right now. And the hope is that as we come into a new administration, that they will quickly be able to regain some attention in those settings and be able to help move things forward very quickly. And so I know you guys have other sort of local issues that are political, but to me, having an administration that's going to care about the rest of the world is going to be like hugely important as we roll out this vaccine.
Thank you, Tanya. Yeah,
so, yeah, Terry, I just want to put a longer lens on your question.
Mm-hmm.
The other day, for whatever reason, I was on the internet looking at the leadership of various hospitals in New York City. Structural racism impacts who our leaders are. And we have to start, at least in my stage of my career, look at the legacy. So our conversation is, how do we get African Americans and other underrepresented minorities into medical school, into residency programs, into our hospitals to become leaders of our hospitals? We're not only looking at the next generation, as I referred to a young attending who worked with me on this presentation here, happens to be an African American woman, but also looking at middle school and high school. It's not just the next generation, but it's the generation after them as well. And what resonated with me was what Michaela was saying about the polio vaccine, whereas mothers will do more for their children than they will for themselves. They'll do more for their families than they will for ourselves. So women, right or wrong, for whatever reasons, are the motivators and the doers in many societies. So those are the two thoughts I had in reaction. Leadership is really important. We don't have it today, but we have an obligation to the upcoming generations to cultivate and nurture our future leaders.
Thank you. Anything to add, anybody? Okay. So I think that could not be a more important thing to say. And I think structural racism is embedded in everything. And I am hoping that what we saw in this country, the disgraceful things we've seen, is going to blow that open at a much deeper level. My hope is that the gig is kind of up on, kind of the structural racism in which we live in every institution. But anyway, there are some questions about certain populations within the vaccine trial. Do we know anything about transgender individuals going through hormone therapy, Asians, and those with comorbidities? Were any of these folks included?
So there was absolutely no information in terms of transgender individuals. Literally for both, and I thought that the gender breakdowns are very poorly done in both of the Moderna and Pfizer documentations. They essentially said 49% female, and that's the extent to it. In terms of the comorbidities in both vaccination trials, there were individuals that had diabetes, obesity, and heart disease. I think those were the three comorbidities that were recruited for. And then in the Moderna vaccine, 4.7% Asian. And then for the Pfizer vaccine, I have it right here. I think it was around that same, 4.4% Asian. And I think that addresses that question.
Yeah, sadly, thank you. We have actually about 10 minutes left. So I wanted to actually ask, I want to say again that for those of us who worked in HIV, it's just astounding how we do not use what we know, right? I mean, you can pile up the best practices this high and they're mostly not followed anywhere. So this issue of leadership is critical. And of course, having people who understand all the complexity, obviously people of color, but community involved is critical. And it seems to be something that just people will not learn. So just to say that, but what I wanted to know for the last round is, so we're sitting at Mailman in Washington Heights. We actually have a huge student mobilization to help with COVID just generally. What is it that we can do at Mailman to help with this whole situation? Because I think, it's just massive what needs to be done. So any thoughts for our students and actually our Mailman community on how we could be of further assistance? Anybody?
Well, I'll just give it a go because I think Mailman is both, has a very good reputation, of course, in the U.S., but also as a global brand. And I do think that partnerships around the world, continued research and advocacy with like WHO and other probably regional groups around the world is going to be really important. I have, and not that this is their job yet, but I've been trying to look closely at what's coming out of the COVID, I think it's called transition team under Biden-Harris. And I see very little being discussed other than sort of our challenges here in the US. And I'd like us to be a little bit more conscious of how all these things connect, because they do, and to speak more about that. And I think, Mailman has some opportunity to do that in the venues and networks that it sits in. So I would like to see us have a little bit more of a, it's a global pandemic, so a global discussion, I think would be really, really important as we move forward, and not to just seem so insulated and concerned just about what's happening in our own communities. And I think that will have a good reflection, not just on us in the world, but also in our communities, seeing when we talk about sort of the structural racism and problems, seeing how other countries are handling this, how their marginalized communities, Black communities in other parts of the world are also being able to deal with these issues, I think will be very good for our own populations.
Thank you. Michaela?
And I'll add to that in terms of Mailman, specific things that we can do. So as in academia, academics have a certain privilege to be able to kind of say what's on their mind, because we're not tied. I mean, we do have government funding and such, but we're not tied down in the same way that individuals might be if they're politicians or different types of organizations. So I would say that one thing that we can do is to speak in very plain language about what's going on. And I really appreciated Michelle very plainly, saying that the systemic racism has been constructed by white people, and it is not the job of people of color to dismantle it. It's the job of white people to recognize it, that that's what's been constructed, that is what has been in place, and to address it. And so I think that institutions like Mailman, which are largely white, largely privileged, and who have contributed to these types of systemic racism and constructs, and actually what I would call now, because I have the privilege of being an academic, so I would actually call it like systemic white supremacy, really, because that's what it is. We can start calling things out more frankly that other people don't have the opportunity. So, and especially for our students. you can call a spade in essentially any kind of setting in ways that none of us can in such plain language.
Thank you, Michaela. Michelle, anything to add there?
Yeah, just unmuting the unmute. The collaboration, the private-public, I'm public, taxpayer dollars support health and hospitals. But even beyond that, the expertise that's at Pop Health, the expertise that's at Mailman. So we're clinicians. We don't necessarily, we do have a data team, but we're not full of epidemiologists or researchers. Just the collaboration on the effort, the way you and I did how many decades ago. You take the clinical experience, you share it with the people who know how to take that experience and magnify it and do something with it, whether it's through the legislature, whatever branch of government, but there's a way to affect change through collaboration. And I'm also thinking about collaborating. I got a call from someone from Mailman over the weekend who's connected to grassroots domestic workers who are undocumented, able to make that connection for that organization with the Department of Health so there can be a targeted effort towards that population, the undocumented domestic workers. So it's about Mailman can be the collaborator. They can bring the science, the epidemiologist and the connections with the communities, and we can link up together and move forward.
Great, thank you. So we're only got 5 minutes left. I think that this has been such a rich conversation and so complicated, which is exactly what we need, is complicated conversations that are fact-based and that acknowledge what we know and what we don't know. And also we need to be much more strategic about kind of tracing back, if you will, the white supremacist of a lot of what we're seeing on the ground. And I think we have to teach that. And I think we are making progress in really kind of looking at every class we offer and how much are we illuminating the history that has created these horrible disparities. We need to stop just piling up the numbers of disparities and we need to fix it. So I think each of you is very much engaged in that process. And I think that's really, really important for students to see. I do want to say in our long history together, Michelle, for example, has done just the very radical thing of telling the truth. And that is a very radical thing in many contexts. So, I'm hoping the students really are looking at the three of you and really learning. So any last comments? I'll invite you to make any last comments before we close out.
Yeah, the only thing, to go back to your other question, what can Mailman do? So I was listening to both speakers, and you're both invited to come to health and hospitals and help educate us.
There you go. There you go. Any last thoughts?
Thank you, Michelle. And I just wanted to lift up that there's been so many great questions in the Q&A box, and a lot of them that we can't get to specifically, but just invite people to reach out to us and you know, we can further the discussion, because we're just really at the beginning of this, and there's so much that's going to happen, you know, in the weeks and months to come. And I think this discussion will have to continue. So
absolutely.
And the last thing I'll say is that when, for ourselves, thinking about vaccination or when speaking to somebody else that might be vaccine hesitant, I think one thing that's really important to remind ourselves on a human level is that having anxiety and fear, and then also the mistrust, the mistrust is well placed for people of color in the medical establishment. And in general, the anxiety and fear that comes along with vaccination it's a normal response to a crisis situation and the unknown that we're facing. So I think that one thing when having these conversations with people is just to always remember that's a normal reaction, and so to gauge that accordingly.
Okay, well, thank you. We are going to do a series. We're organizing a panel on the vaccine and incarcerated people, and we will continue to try to kind of go deep into what's happening, including equitable distribution around the world as we proceed. And I think that, we have to be engaged. Obviously, very hopeful is, what we saw in Georgia. Very hopeful to me is the leadership we saw from Black women in HIV. We saw mountains moved consistently. So the leadership that we're seeing all around the world is not to be underestimated. So we just want to make sure we're all working together and are as strategic as possible in thinking about the structures that create these situations and illuminating that at a deeper level as a part of public health. So thank you all so much. This has been just an honor to participate in, and thank you, our very large audience. And please reach out if we didn't get to your questions. And it's our first day of school here at Mailman, so welcome back. Thank you.
Thank you, Terry.
Thank you, Terry.
Take care.
Thank you all.
Bye.